All right, everybody. So we finished up the other night talking about the elderly community and getting access to their drugs, whether it's a monetary thing or, in this case, the physical attributes of um, getting into the pill bottles of what they have. We're going to introduce a concept tonight called polypharmacy, where we may get calls for individuals who have gone drug shopping with their PCPs based on medications, and we'll talk a little bit about that. So one of the things that we have to worry about is when we look at individuals that do have medical histories, and they're elderly, or even, as they get older, and, none of you guys understand this yet. You will. Give it about 10, 15 years, where you become very, very, very forgetful. It's not onset of dementia or an organic brain syndrome. It's just basically people forget to do things. But one of the things that with the elderly is being able to take their drugs in a timely and manner. Things that we need to do when we go on scene, talk to these people and everything else like that. After that is, how do they take their meds? Do they have those little pill boxes that they can put things? Do they have reminders on their phone if they are technologically advanced? If they can't get to the pharmacy anymore and they're homebound, do they? A lot of pharmacies now have mail order as well as if it's a retail pharmacy delivery type. Can they read are they able to read larger font on medication? Listings, as well as do they have clear, simple directions? Take this, 3 times a day. For us, that would be TID, but most people don't know medical terminology when it comes to the drugs. So it becomes very important when someone is discharged from the hospital or go to see the physician that they have clear, simple directions when it comes to taking their medication on a timely manner. One of the hardest things when we talk about that is, does an elderly patient really understand what is going on with their and the treatment that they need to go by? One of the good things to help keep these people with it as well is regular exercise as well as a good diet. When we start talking about the elderly, we have to start worrying about their financial situation as well. We'll talk a little bit about more with that. But again, having individuals get up and walk around the block, that's why, the whole COVID limitations of what's going on now, some of the elderly patients are becoming very, very basically being couch potatoes. They can't go out. I know that's a problem with my in-laws, and both my in-laws are very active. They're 75 years old. They usually get out after dinner and they try to walk at least a mile, mile and a half. And they have a good diet. We cook for them on the weekends, everything else like that. But because of this lack of mobility can have detrimental physical as well as emotional aspects, being isolated. This weekend for Easter, I don't know if anybody else tried it, but we cooked dinner. My 18-year-old took it over safely, dropped it off outside, and then he came back and we all sat around my wife's iPhone and we had dinner with my in-laws and my sister-in-law all via Zoom, and they loved it. It was one of the highlights of their day. In fact, they liked it so much. Next Saturday, we're doing it again for dinner. And this lack of mobility, again, detrimental physical effects. And why do I point that out is because when we see here, I put a little blurb here. We'll get into it a little bit more here, but talking about geriatric patients that suffer hip fractures. And here you can see from this article in Usual Care, the reported 1-year mortality. This people who die up to 12 months after sustaining a hip fracture have been estimated anywhere between 14 to 58% of those individuals that have that fracture basically die within 14 to 58%. This relative risk increases 4% per year. Well, that means that these individuals are walking more. They're trying to get them out, but they're also, and again, the majority of this stuff comes from falling out of bed. Usually the first year after the hip fracture appears to be the most critical time. Speaking, from personal experience, that's how my aunt passed away. She ended up having a hip fracture, fell out of bed in the nursing home, and within a year she was dead. But if we, again, further looking at this year mortality, the number of hip fractures in the U.S. could total 840,000, almost 1 million by 2040. Older adults are the fastest growing segment. Population age 65 is predicted to be more than double by 2050. Okay, it's going to increase from 39 million to 89 million. It's estimated that 1 in 3 women and 1 in 12 men will sustain a hip fracture in their lifetime. And there's pathology behind that. Why do more women get more hip injuries secondary relative to men? And that's due to osteoporosis and calcium depletion over the years. But it's reported that 86% of hip fractures occur in individuals aged 65 years and older. Well, this article that I pulled is 10 years old. So those numbers are increasing. And again, if we look at the epidemiology of all that stuff, it's the reason why as they get older, individuals suffer from poor nutrition. Again, as they get older, most individuals are on fixed incomes. That fixed income, you gotta, do you pay the rent? Do you pay the heat? Do you get food? Do you get, your drugs this week or something like that? Another thing is they have difficulty with elimination, solid and liquid waste. So if they are unable to get rid of what they're bringing in, that can add to the patho of these individuals. Because these individuals have these added problems, what we end up seeing is they're at higher risk for illness secondary to the breakdown of their integumentary system. They don't just get lacerations. The skin breaks down even more to where we end up getting skin tears. And when we end up getting skin tears, these individuals end up with infections much, much easier. They have greater predisposition for falls. Again, whether it's a vision issue, balance issue, safety at their house or anything else like that. They lose their independence and or confidence of living alone. This all adds on top of that. Most individuals, if they don't have an active lifestyle, whether or not, staying with friends, staying with family or anything else like that, they start to feel old. And because of that, and we're all dealing with this right now with the isolation, the lack of social network, we've been all told to stay at home. Imagine what's going on with them when they can't go out to bingo or anything else like that, or if they can't see, like I said, I have 2 very active in-laws, 75 years old, and they miss their grandchildren. So if you can't get anything, even if they're not technologically advanced, which my in-laws are, they feel isolated and they lack that social network. Perhaps they were already depressed. Now they have nothing to do. They may end up becoming even worse as they go along. And again, discussed it already, fall-related injuries are going to be the leading cause of accidental death and higher mortality among the elderly. And they break these 2 things down that we just talked about here with the pathophysiology, but we have to look at what are known as intrinsic and extrinsic issues. Anything that's known as intrinsic is related directly to the patient. Okay, their history. Do they have an illness? What is their past medical history? Somebody that has a history of a stroke or poor mobility is going to have a higher chance for illness. That's an intrinsic history. When we start talking about extrinsic, these are things that are related to their environment that may or may not increase or decrease their pathophysiology. What's their home environment like? Do they live by themselves? Do they live with a spouse? Do they have to take on renters or something like that? Again, the big issue here is to see money. Most elderly individuals, unless they are very, very, very well off, live off of a very fixed income. Also, because of this home environment, please realize as we are designated reporters, not only for elder, but also pretty much any type of abuse. Elder abuse is a very real possibility in today's society, whether that be child to parent, or spouse to parent, or even someone that is not related, is a renter or something like that. There may be a history of physical abuse. And if there is an injury that doesn't match the story, it's up to you to follow up on that and report it and document very, very thoroughly. Document very thoroughly in all those issues. When we start talking and assessing these individuals, please remember there might be some type of communication difficulty, and it may not be pathologically related. There may not be a disease process. It just may be that they are getting old. There's nothing wrong with that. Getting old is a byproduct of growing up. And it's one of those things that some people, have a problem with, but also as providers, we have to realize that we have to communicate with them. Please note that some elderly have impaired vision and or blindness, impaired or loss of hearing. And again, with that, it may be that they are, not hard of they may be hard of hearing without their devices, whether it be a hearing aid or whatnot. Seeing some, especially now that we're getting on scene and we have our face masks on, maybe there's individuals that may end up, be hard of hearing, but they got pretty good at reading lips. So that may be problematic as well. And in that impaired vision, for those of us that wear glasses or contacts, please realize it's a very real thing. Once you remove your glasses, your sense of hearing goes down as well. Altered sense of taste or smell. Also, foods taste differently. So if somebody once thought something was good, they don't like it anymore, something like that as they get older. And then they also have a lower sensitivity to pain or touch. This also becomes very prevalent when you end up getting somebody who's cold. Most elderly, due to low iron, anemia, or something like that, may end up trying to warm something up and they don't realize that it's so hot and they end up getting burns. One of the things that we have to discuss, especially when it comes to the elderly, what are ADLs? ADLs are known as activities of daily living. And if you look at the ICD-9s, or if you look at anything that goes along with taking care of the elderly, whether or not they become institutionalized or if they go to a nursing home or rehab, one of the things that everybody wants to know about is how many ADLs can they do. And basically, it's the activity of daily living, and we'll talk specifically about those ADLs here in a few slides here. But one of the things talking about continence and elimination, one of the basic things that we do as humans is take care of ourselves. Very young, our parents do it. But from that age of about maybe 7 until we can't do it anymore, being able to urinate and void is something that we do on our own. It's very private. But again, when we start talking about the elderly, we end up requiring people to do it. So most of the time, the elderly are very often embarrassed to talk about continence and elimination. They feel stigmatized, isolated, helpless. I mean, think about it. How would you feel if you had to wear an adult diaper all day? How would you feel if you had to have, everything else is going well, but you have problems, whether for the male it's prostate problems, females, any number, UTIs, any number of issues that can cause urinary or fecal incontinence. Telling somebody, oh, did you poop yourself or something like that? Or it's imagine how you would feel if you did that. Even in the back of the truck, I know, if someone passed gas or someone had a bowel movement, they were unable to hold things and, just off the cuff, you're sitting in the captain's chair, the patient's looking in the back, they're alert with it. They had a momentary lapse of continence and you to your partner, hey, our patient just SHIT themselves. How do you think that would make the patient feel in that? One of the things that we do have to worry about, and again, we'll talk about this later with pathophysiology going down the road, is skin breakdown. If you've ever taken care of those nursing home patients where they sit in a Geri chair all day, nobody takes care of them or something like that, this can lead to breakdown of the skin. And we'll talk about ulcers that can create and wound care down the road that is causing a lot of problems down the road, which do lead to sepsis. Please note that, for individuals to be continent of not only urine, but also the solid waste, they have to have an intact GI, GU tract. They have to be able to maintain the sphincter mechanisms, meaning they have to have neurological impact as organic brain syndromes, which is the general term that encompasses dementia, Alzheimer's, muscular dystrophy, multiple sclerosis, stuff that is organic, that can cause problems down the road, forgetfulness, as well as they have to be able to get to where they need to go and remember that they need to go with that. And again, some of the processes that can alter ADLs, the big ones, as I said, the organic brain syndromes, but again, the strokes. When an individual has a CVA, whether it be occlusive or hemorrhagic, can change an individual's ability to deal with their ADLs. Some of the things that can cause problems when we look at altering ADLs is going to be drug therapy. Big one that we always talk about is utilization of opioids. Please realize that opioids cause a general slowing of a patient's digestive tract and everything else like that. Things become impacted. One of the things that we should be talking about, with our patients, and I know it seems funny because we always laugh about nursing asking, but ask a patient when their last bowel movement was. You'd be amazed. Patients can become easily septic later on in life if they haven't had a bowel movement for 3 or 4 days. Where's all of that waste being stored up with that as we move along? So that's always something to think about. Individuals, as they get older, their bladder capacity decreases. Males typically will end up having to may have enlarged prostate, which causes their ability to pass urine very, very difficult. Multiple catheters can lead to UTIs and issues along with that, as well as stroke can cause sphincter dysfunction. Diarrhea or a lack of physical sensation when it comes to that. Individuals, if you've ever taken care of someone who has had a colostomy, they can't control it. It just comes out. One of those things is if a patient does have a colostomy bag, knowing that it's located on the left side, and you don't want to put a stretcher strap directly over it, because if you pull it too tight, you can fracture the bottom of the bag, and next thing you know, you have fecal waste all running down the patient's left side. As well as if somebody has had a colostomy short term, if it is reversed, you may end up have somebody that is unable to feel when they need to have a bowel movement, secondary to reversal issues or neurological issues with that. Most of these patients do wear adult diapers, some type of absorptive material in the back. And again, I know it's very difficult for us to put someone on a bedpan, but again, if you end up needing to, modesty and dignity are the utmost care. Please remember, in the back of your ambulance, if you're doing a long transport or something like that, please remember at night the lights are on in the back. Most ambulances with the lights on in the back can be seen from the outside, so please remember that. And again, patients that can't eliminate certain things can lead to serious issues, UTI being one of them. But again, we also see that with constipation, with the solid waste, colonic ulceration, intestinal obstruction, urinary retention as we go along, in primary leads to, in this case, sepsis. And again, I led to a little bit earlier, drugs that can cause constipation. We're going to see the opioids being the big one, especially the motility of stuff through the digestive tract. Anticholinergics, cation-containing agents, neurally active agents, diuretics. Other thing, don't forget Benadryl. Individuals that will take antihistamines or something like that, please realize that that just doesn't affect the nasal cavity and the release of histamine from the mast cells. That also retains all of the liquid from the GI system, which over time can lead to constipation, especially if somebody's taking cold and flu-like liquid NyQuil or something like that for general over-the-counter stuff. That can also add to problems for that. Regardless of your patient, always standard precautions. We've been talking about it lately, where once we're out of this COVID issue, What is PPE going to look like? Standard precautions. It's the opinion of several of my cohorts across the country that perhaps we're going to see PPE that is started now during COVID, the yellow isolation gowns, all gloves, everything else like that. That may become the norm on every call. I mean, when you think about it, we're worried about intubating these COVID-19 patients, but when you open up somebody's airway and you're down there face to face with somebody, what else are you bringing up? We don't know. So it's going to be interesting to see how we rebound from this. But again, standard precautions for all these patients. When you walk into the house, when you take care of these patients, whether you go to the nursing home or anything else like that, real quick. I mean, you don't need to do, a 10-hour review, but what's their living situation? Do they have assistance? And it goes into the whole ADL thing. What's their activity level for that day? Do they have a network social support? Oh, have you talked to your daughter today? Everything else like that. Those are just little things that you can pick up on. Do they have a network social support? What's their overall level of independence? If you go into a nursing home, you're going to assume that they have 24-hour coverage. But what happens if you go into a assisted living facility? If you end up going into some type of SNF or something like that? What's their med history? Get everything that you can that may lead you down the road, because again, some of these people may not believe that they have a medical history because they're taking all these different medications, and that's where you have to be the Sherlock Holmes to figure that out. One of the things, sleep patterns as an individual gets older get all wonky. Some people are up all night, sleep all day. My wife's grandmother said she never slept. No, that's because she was up all night, but then she took cat naps during the day. But she felt because she was up all night, she didn't sleep at all. We know also, too, with that medication history, some older individuals, as they get, especially now, the baby boomers, those individuals that were teenagers in the 1960s, may partake in a little bit of marijuana or edibles before they go to bed. I know of a couple people that had, they're in their 70s and they get a hold of some heroin, or they keep their OxyContin and they use that to sleep. So at that point, it's something to just in conversation. And you have to be able to look around, and that comes into your assessment, either you or your partner. If you go into somebody's house, hey, can I go look and see what's in your cupboards? Look in the kitchen, look in the refrigerator, look in the cupboards. If they're type 2, type 1 diabetics, look to see if they have any insulin in the refrigerator. Most of that stuff has to be. If you walk in and somebody's on, all they have is two 12 packs of Coors Light and a box of old moldy Chinese food, perhaps they're not eating very well. But if they have that much booze in the house, perhaps they may be alcoholics. Don't ever assume just because somebody says, I just drink beer, that they're not an alcoholic. With my mother, before she passed away, anytime she would go into the hospital, even though we had put it in her chart, we would have to tell them that my mother was an alcoholic and would drink a case of beer a day. And that becomes very, very important to know, because if an alcoholic's, in the hospital and they don't get their requisite alcohol per day, they may end up going through the DTs, and that becomes problematic. Always, do a breathing or respiratory assessment. Do your doorway assessment. Get a pulse ox. If you need a capnography, throw that on. But again, that doorway assessment, there are some individuals that do call 911 because they're bored, they're living, they need to get out, they want to do something. So they may just call us for that social interaction. But, look at somebody from far away. See how they're, even 3 seconds, see how they're acting before you get in there. If somebody's complaining of abdominal pain, ask them when their last bowel movement was. Ask them if they've had coffee ground stool or emesis in that manner. And I know it sounds disgusting, but send somebody into the bathroom to look in the toilet water. Hopefully they met, when was their last BM? Was it solid? Was it soft? Well, and that can tell you a lot about their overall general well-being. Nausea, vomiting, coffee ground emesis, that also with the last BM, looking to see if they've had blood in the stool. Please remember, assessing and looking at blood in either or liquid or solid form can be very informative. If you have stool and it's bright red coming out, more than likely that bright red blood's coming from a hemorrhoid. If it ends up being some type of red or dark red that is included in the stool, it tends to be somewhere in between. If it gets black and that's higher up into the system, and if you end up with coffee ground emesis, that means that they're bleeding in their stomach somewhere, and the blood's been digested a little bit, and it's brought up. One thing to remember too, when you do take individuals to the hospital, ask them to smile when you look at that. What's their dental care? You guys have all read the article regarding the biofilms and looking at dental care. Do they have dentures? Do they use them? Don't forget them in your transport. But also, there's a lot of cardiac issues that could be associated with poor dental care. You'll find individuals getting cardiac issues if they end up having some type of dental work, or are they on aspirin. All these things can tie into that. And look at their medical problems. What's their history? Look at their drugs that they're currently taking. It can add a lot to that. And that also includes their over-the-counter drugs. Are they taking Claritin? Are they taking Benadryl to help dry things up? Advil PM. Don't forget, what makes it a PM drug? The Benadryl. All right, so somebody may be taking something to help them sleep or something like that, and they may not realize that it has Benadryl. And again, Benadryl doesn't dry up the nasal mucosa. It dries up all the mucosa. There I also have the alcoholism. Please remember, DTs are a life-threatening condition that gets somebody admitted to the hospital. Now, again, if somebody, the younger crowd, if they're addicted to heroin or something like that, and they're just going through the withdrawal, most of the time, unless there's a suicide issue or something like that, or most people that are trying to get admitted for detox, if they're addicted to an opioid, they don't get admitted just because they're going through withdrawal. That's not a big deal. They can do outpatient. If it's alcohol, they're going to be inpatient because of the DT issues. Again, compounding psychological disorders that we're going to see are problematic, whether or not they have some type of psychoses going on. If you ever want to have wonderful reading, look at the DSM-5, Diagnostic Statistical Manual, the 5th edition. When we start looking at the axes of psychological disorders, it will tell you a lot. Also, where are they at in their monetary schemes? Most of these individuals, as we've talked about already, are on a low to fixed income. So they may be living below the poverty level. So their only food that they are getting are secondary to Meals on Wheels. Or you may end up coming across that elderly couple that lives off of Caesar cat food, which, and when you think about it, you're like, ooh, how could somebody do that? Well, when you go to Dollar General and you have a total of $10 to spend, you can get 10 cans of cat food for $1. You're looking at quantity over quality at that point. Other things that go along with that malnutrition, the cat food concepts, or just the very plain things that you can buy a lot of, tuna fish and stuff like that, most of that single food stuff that you're going to do will have vitamin deficiencies, which can add to the pathology and the disease processes. Have they been outside for a while? Please remember that direct sunlight, not only I know makes you feel, especially those that work night term, having access to the UV rays and the vitamin D processes that go along in our skin are extremely, extremely important to us. A lot of people may not realize that as they get older, but that's, that adds to those vitamin deficiencies. Dehydration. Most people, drinking water is very, very, very important. We notice too, these elderly individuals, if they do get a UTI, they don't want to urinate because it hurts. So they stop drinking. You stop drinking, eventually you stop urinating. You stop urinating. If that bacteria builds up, progressively gets worse and worse and worse. Also, these individuals, just because of their metabolism, may end up becoming hypo or hyperglycemic. So always grab a glucose on these individuals if there's slightly altered mental status or something like that. And again, it's one of those data sets. If you have somebody that's not acting right, it could be dehydration. It could be an electrolyte or a vitamin deficiency. But those are kind of hard to fix right away. Hypoglycemia is very easy. And if they are hyperglycemic, become DKA or something like that, we'll talk about that later. There's not much we can do pre-hospitally other than giving them fluid, but it's something we can little tick box and understand where our patient's going to be. But again, one of the problems when we assess these elderly patients is, what is the patient's chief complaint that they called you for right now versus what's the patient's primary problem? Because again, most of these individuals, as we talked about last time, have at least 6 different complaints going on or 6 different pathological issues moving on at once. We can't fix them all. We got 20 minutes, 30 minutes to take care of the most life-threatening ones. So while we can figure out on our way, we need to be able to fix those threat to life issues. We're not going to be able to fix their their overall diarrhea. We can treat for the signs and symptoms of diarrhea with fluid and a little bit of oxygen. But again, do they have Crohn's disease? Is there something else like that? But regardless, we have to be able to see the changes in patients' responses, whether that is secondary to an organic brain syndrome or something like that. But regardless, I know there's some providers out there that view the elderly as a waste on the system or something like that. But all of our patients, every one of our patients, as I told you from day one, deserve a full assessment and being treated with patient respect and kindness. All right. And, sir, madam, not calling them honey, sweet, and dear. Hi, sir, hi, madam. And if they, I'll ask them to, call them by first name. If not, it's always been appropriate to call them Mr. or Mrs. once you find out their last name. Treat them just like you would want somebody else to treat your grandparents. Also, a lot of people get very short-sighted and temperamental when it comes because these individuals, they're trying to tell you they may not understand where your line of questioning is going. Okay, but again, right then and there, this patient is your most important patient, and it takes time to elicit responses from them. Don't forget they all have multiple diseases, multiple meds, and then because of that, they may have increased incident med errors, drug interactions, and noncompliance for that stuff. Remember, hard of hearing makes it almost impossible to obtain history. Determine, and again, this becomes a HIPAA issue, but always ask somebody if they're there, hey, Mr. or Mrs. Johnson said I could talk to you. Are you okay with that? But always get the patient's permission to talk to somebody about their needs, or maybe something that the family member may or may not know about. And then I will tell you right now, having more than one family member on scene can be a disaster, train wreck waiting to happen, depending on what's going on. And some of that information that I told you to read by Dr. Fred and DNR and the patient's code status and everything else like that will only add to that problem. Don't shout at your patients. There's one thing to why don't you just kneel down to them, talk to their ear a little bit closer, but you don't want to, sound like you're overtly aggressive to them. And if they do be, confirmed deafness, maybe a pre-existing condition, but what if they don't have their hearing aid in or something like that? Or what if they English is a second language or something like that? These are all questions that you have to be aware of. As they get older, they may have trouble with speech. Always introduce yourself. Let them know who you are, especially if you work with a volunteer organization where you may or may not show up in uniform. That's always be mindful of that. Also, please realize that, especially with an influx of immigrants into our service areas, we take on a very authoritative stance sometimes. And there may be individuals who distrust EMS, even the very elderly. So please be mindful of those cultural awarenesses with that. But when you talk to them, distinctly, respectfully, and slowly. All right. Speak to the patient first rather than family members. Don't just bypass them and don't just blow them off. Your first 20 seconds is the most important time dealing with every patient. And then speak face to face and at eye level with eye contact, just like you would with a pediatric patient. Like Andy was talking about last week, some of us are pretty big when compared to an elderly patient, that's hunched over or something like that, very authoritative. And here you can see this young lady sitting here on her knees. Granted, this is not your best situation if this with this individual had they this is your initial contact, but I'm assuming that this individual here is when she's discussing what's going on with the elderly gentleman here, she asked for permission, came in, talked that way, so she felt very comfortable getting down and getting at that eye contact to where she could take care of that patient. But also, this is a husband and wife. You will find out the older you get, if you are married or have that significant other in your life, especially when it comes to the relationship of husband and wife in this manner, the husband may defer all those questions because the wife knows that more so than the husband does. So, kind of that's a learn on the fly, go with the best that you can along the way. All right. And again, we've talked about that hearing aid glasses, get them for them. If you don't have a hearing aid available, offer up your stethoscope. You can speak into that, and that will amplify it. Turn on room lights. Most individuals during the dark have problems seeing during the dark, especially if they have glaucoma or cataracts. Display verbal, nonverbal signs of concern and empathy. It's amazing what you can accomplish with a soft hand, shaking somebody's hand or something like that. Politeness, preserve dignity. Rephrase questions. Don't use big words. Make sure that the patient hears you. A lot of times, shake your head, yes. Turn if no. Explain what you're doing and why you are doing it. Do not assume just because they called 911, they actually want you there, or perhaps they don't want any care done. Or the one thing that's very big with the elderly is, can they afford this ambulance trip? Multiple times over my career, somebody needed to go to the hospital, but they're like, I can't afford it. I can't afford it. We're here to take care of the patient, and you're going to have to come up with your own way to answer that in that ability. And again, just because they're old doesn't mean that they have a decreased mental status, but the majority of the time, as they get older, it may diminish a little bit. That may be caused secondary to delirium or confusion. They're easily distracted. They're restless. They haven't slept for 3 days because of the pain. They didn't want to bother their family members. They didn't want to call the hospital. They know they're busy. They're afraid. Anxiety, excitability, or they may express that in some type of hostility, anxiety. Think about your own characteristics of when you become scared, frightened, hungry, hangry. Most of us display some type of anxiety in some way, shape, or form. But please realize that holds true for the elderly as well. Senility, OBS, can manifest similarly, I can't pronounce that word. But again, determine, and I know this is a joke in EMS, especially when we go to these sniffs. Well, the patient has an altered mental status. Okay, well, what were they like before? I don't know, not like that, or they're different. Oh, well, wait, they've been demented, or they have Alzheimer's or something like that for the past 10 years, but they're different now. And I know that's a question that will abound, especially that's not my patient, I just came on, or something like that, and it's very hard for us to decipher what is the norm with that. But we have to play that Sherlock Holmes in that manner. Take a temperature, take a glucose, try to find out what's normal, what's abnormal. Getting the history, getting the meds, and all that other stuff adds on to that. So this is just a diagram here that kind of looks at the process of what can cause, in this case, altered mental status. A couple different things that we could look at. One, is it an organic brain syndrome that is related to dementia, Alzheimer's, or something like that? Could this patient have an infection? Could they be septic? Okay, when was the last time they had a bowel movement or had were continent of urine? Did they take too much medication? Okay, they're supposed to take OxyContin 3 times a day. Well, they forgot they took it, twice today already, and took it twice more. Well, the OCs knocked them out. Are they anemic? Do they have end-stage renal failure? This can all cause altered mental status. Do they have a GI bleed somewhere along the way with that? Are they hypoxic or something along the way? Are they COPDers? Are they too hot, too cold? We already talked on the hypoglycemia or hyperglycemia. Is there some type of head injury, TBI or something like that, that was undiagnosed? Did they, one of those questions? Oh, have you fallen recently? Did your wife hit you upside the head with a broomstick or something like that? It's these little things that we can ask our patients to help to chip away at what we're trying to find out. Or you hook them up to the monitor. Have they had a heart attack recently? Are they showing any type of monitor dysrhythmias? Are they in VTAC? Are they in a new atrial fib or something like that? These are all things that can lead to altered mental status. Or could it all be in one? I mean, think about it. Can you, in your mind's eye, think that all of these issues could be going on at once? If you can remember that shock lecture I did last semester, where we talked about nurse champs, you could tie all of these together, and it becomes problematic as we try to figure out what's actually wrong with our patients. Some other assessment considerations. Do you have a depressed patient? Psychological issues. Are they malnourished, dehydrated, OD? Are they contemplating suicide? Or are they imagining what's going on or coming up with things to get, to cause attention seeking with that? But these are all things, if you want to put it into your assessment question, hey, have you ever thought about hurting yourself with that? Because again, in this article in 2018, one of the higher rates among elderly is suicide. Suicidal behavior in older adults, 65 and over, are a major public issue, where we're seeing that the elderly are committing suicide at approximately 48.7 persons per 100,000 among older white men. There is a cultural difference between suicide when we look at whites versus non-whites. Whites tend to do it more, as well as there are religious, cultural, and ethical issues that go along with that. But that is something to think about. How many of these individuals just get tired, their loved one died, they don't have anything else to live for that they believe, as well as how many of these individuals may or may not have a terminal illness and they want to check out before the disease takes them, or financial considerations. I can tell you of several cases where an individual saw the financial ruin that a given disease may cause them or their families, and they decided that it wasn't worth it. So they decided to terminate their lives prior to the disease taking hold. Other things that you assess your patient: look, drug, alcohol, all those things. Smell. Take a smell around. What's going on? Does it smell like alcohol? Look for those medic alert tags, vials of life, ID items. Do they have a when you listen to lung sounds or you put the monitor on, look up higher, look to see if they have a pacemaker, something like that. Ask for any recent surgeries, any signs of abuse or neglect. Fatiguing individuals, especially when they get elderly, they may be easily fatigued. Going into a house, this time of year, it's 70 degrees outside. It's wonderful. Elderly individuals may have the heater on because they're cold, or they're wrapped in multiple layers of clothing. As well as, please realize that during the cold months, because an individual that's living at home can't afford their electric or their heating bill, may end up keeping the heating at 50 degrees. And they may end up, I've had cases where you show up to the house, it's 50 degrees, and someone is frozen to death. Always tell patients what you're going to do. Patient may not complain of anything, family member called. Please remember, regardless, these individuals, unless there's a power of attorney or medical power of attorney, still have the right to refuse. But again, it's our job to make sure everything's on the uppity up. And if they need to go, tell them, hey, this is what we need to do. Get command involved, get other family members involved. These calls, typically, when they don't want to go, become very in-depth. And this is where you'll see a lot of the mobile integrated healthcare and community paramedicine services come into play. And it's very difficult sometimes to know what a chronic disease is versus the acute problem. But again, look for your life threats, those ABC issues, and work from there. Try to tailor your management to fit the illness, injury, or overall health. be mindful of any neurologic vital signs or cardiac statuses as you go along. And again, transporting our patients nice and easy versus lights and sirens. Please remember what can happen to your sympathetic nervous system if you got lights and sirens. You're going to increase patient anxiety, heart rate's going to go up, cardiac output, yes, will go up on the back end, but also myocardial oxygen demand, everything else like that. So taking patients to the hospital nice and easy, unless it is a true life-threatening emergency where you need some help right now, probably benefits your patient more than not. And give them the emotional support. I mean, you're not going to give them your phone number. You're not going to give them $100. But, hey, tell them everything's going to be, you're going to try your best. We're going to get you to the hospital, get you checked out, and, get you as well as we can. And again, people are going to express their feelings to you. Don't trivialize their fears, because, and again, keep your eye out for potential abuse. Getting somebody in the back of an ambulance by themselves may yield you some time to talk to them. And again, that may come in a form of nonverbal, just like separating a parent from a child or something like that, separating a caretaker from the elderly individual may become problematic, but that's why the police separate, suspects to get true stories from everybody. And again, when you assess them, don't be judgmental. Confirm what they're saying, avoid those communication breakdowns, and understand that they are adults. All right, we're providing a service for them, and so you take care of them. So this is the end of this first part. When we come back on Wednesday, when we talk about part 2 of geriatrics, we're going to go more into disease states when we look at respiratory, cardiac, endocrinology, all that other stuff. So unless anybody has any questions, and I've been watching the chat page here, I haven't seen anything, we're going to go ahead and let's take a 15-minute break, and